the lecturers. Welcome to Australian-Indonesian joint lectures. And today's topic will be different from the other series. So we focus today on the community ophthalmology. And we are privileged to have two compelling lectures lined up. Dr. Yeni will discuss about the role of the key informants in eye care or eye health program. And Dr. Fletcher from Western Australia will share the strategies to bridge the health disparities in Western Australia. And so, without further ado, I will invite Dr. Yeni first to share her speech or lectures. Please, Dr. Yeni, time is yours.
Yeah, thank you, Dr. Rumita. Thank you for having me on this series. Good evening, everyone. Good evening, Dr. Fletcher, Dr. Arty, and Dr. Mita also as a moderator. This evening, I would like to share about the role of key informants in eye care program. Does my slide can be seen, Dr. Mita?
Yes, clear, Dr. Yeni.
Okay. Okay, so back to our prevalence of blindness in Indonesia, we have a RAP survey on 2015 and 2016 that show that the prevalence of blindness in Indonesia is 3%. Although we seen that in every province or islands, they have a quite different on prevalence of blindness. So there is a gap between province or between islands. So it's in line with the number of blind people globally that reach into 1.1, not a blindness, but a visual impairment population that reach into 1.1 million people, that half of them is cannot access the health or eye health facilities. Excuse me, sorry. This is the number of or the causes of visual impairment in Indonesia. We can see that in blindness category, the causes is still cataract as the major causes, and also in severe visual impairment and moderate visual impairment, cataract is being being major causes of visual impairment. And after cataract, we see that there is a refractive error and glaucoma, and also other posterior segment such as diabetic retinopathy. So we also have latest data on the number of ophthalmologists per province. We can see the supply and demand of the ophthalmologists per province. This data is the courtesy of Prof. Bayu Sasongko, and we see that there is a gap on supply and demand in every province. So in other side, we have a quite big, not quite big, but it's a big burden of eye diseases and also blindness. But in other side, that we have a shortage of ophthalmologists and also the optometrists and other allied health personnel. So in 2020, after the Vision 2020 finished and followed by the 2030 Insight, there was some strategy launched called the Integrated People Center. And this approach is needed for to make sure that all the people have the equity in access. So for everyone and everywhere, they have an access to the eye care services they need. And also, we want to make sure about the quality. Uh, the quality provided is safe, effective, and also timely accessed by the population. And also the responsiveness and participation of the facility, the resilience and also the efficiency of the eye care system in every area in Indonesia or also in globally. So to in line with this approach, actually the government of Indonesia has already start to launch the Vision Center in order to strengthen the primary healthcare. So they already plan to develop more than 20 Vision Center all over Indonesia. And we hope that this Vision Center could be strengthening the primary eye care in the primary health care. But as you know that in primary healthcare, the GPs and also the nurses have a lot of things to do. It's not only the eye problem, but also another diseases that maybe more have a priority than eye diseases. So there is a gap also when we're strengthening the primary healthcare. There is also a shortage of staff uh, that can give the basic primary eye care. So we need someone to help them, so the service is more efficient and also effective. So we known or familiar with the terminology of key informants. What is key informant actually? Key informants is individual who live and work in their communities and who have play vocation role to improve their community's well-being. Usually, this is a community champion, so it could be teacher, it could be the head of the area, it could be a student also. You know, like in Indonesia, we have a scout, yeah, a pramuka. They can be key informants, and usually they become a vital bridge, the one that can close the gaps. So they usually can connect the health system with the underserved population who might otherwise go undetected. And another key informant could be a local leaders. It's often volunteer, or in Indonesia, we usually know them as a cadre. We have a Posyandu cadre, we have a Prolanis cadre, and so on. So why are they matters? Because as I said earlier, that they can bridge critical gaps between the health system and usually in underserved or remote area. They can connect eye care services with rural and resource limited communities where formal health systems struggle to reach. And also they can do the early detection. They can do enable timely identification of uh, simple examinations. They can detect a visual impairment and also blindness. And also they can strengthen the system. They can enhance the health promotions and do the referral. So the health staff can work more efficiently. Uh, there's some data in showing how effective the key informants. There's a report or there's a study from Malawi by Kalua that they use the key informants and comparing with the health surveillance assistant um, to uh, to measure the effectiveness of the childhood blindness patients. Yeah, so they found in the key informants, they found 158 children to have and 20 cases is blind. So to take severe, moderate severe patient, children patient with eye problems, and from 158, they confirmed 20 cases or 20 children are blind. And it will give a 3.2 key eye efficiency ratio compared to the number of children identified by the health surveillance assistant, that the ratio is 29.5. So you know that in finding blind children is very hard because the prevalence is very low. So we need to examine more than 1,000 children just to find one blind children. So in measure the prevalence of childhood blindness, the key informant system is more effective than the conventional health surveillance assistant. So in Bangladesh experience, the productivity of key informant was also high, but they spotlight the gender because in Bangladesh the male key informants identified 2.7 times more blind children than the female. So it's revealed the importance of gender dynamics. It might be different from place to place. Like later we can compare it with Indonesian setting, but it helped that the blind children to be found more easily by the key informant, because usually this key informant knows that if somebody or someone in their neighborhood having a eye problem, so they will bring these children to the doctors or the ophthalmologists. And in Indonesia setting, key informants usually we use for childhood blindness. This is my study from 2011 that we trained like 56 posyandu cadres from 5 hamlets in Makassar district. It's a district in East Jakarta. It's enrolled in this study. We conducted half-day training sessions. Each session is attended by 10 to 15 key informant. So we need like four group, yeah, to have this training. And the result is they found 56 children, and 54 of them is having a completed eye examination at PHC, at primary healthcare. So almost over 90% of the children were brought to the primary healthcare. So it's revealed that all the children and also the parents is very having a trust to this cadre. So I think that all the cadres have already have a good communication skill that finally they can bring almost all the children to have eye examinations. And from 54 that already completed the eye examination, 53 children had eye problems. And it's confirmed that 14 children had a severe visual impairment or blind. So you can see the characteristic of the key informants. All of them is female. In Indonesia setting, the cadre usually of female, yeah. And the age is between 30 to 50 years old, mostly. and they have a moderate education, moderate level of education. And this is the very interesting because most of them is participated in over three health programs. So it's not only for mother and childhood health, but also for chronic diseases and also for another health programs. Yeah. And the result is also show that 70% of the children actually needed an optical services, and almost 30% needed a surgical intervention like cataract operation on both eyes because of the juvenile cataracts. And one child with optic atrophy due to brain tumor needed an orientation or low vision services. So this is the causes of blindness. Most of them is preventable and treatable, and only one is unavoidable. So this is another example from using the key eye. We're using the student as a visionary guardian in school eye health screening program. So we conducted in 5 junior high school in Jakarta with 600 students involved. We do the 2 hours training program for elective students, and the curriculum is already developed in academic way, yeah. And the kappa agreement is 0.7. We found the sensitivity is over 86%, with specificity is 92.5%. So it's show that the accuracy shown by the student is very high. They can help us to triage, yeah, to screen which student having a visual impairment, yeah, by only using the single lines of chart. And this is also our experience in using the key informants for cataract and visual impairment, yeah, moderate visual impairment. Just simply train uh, the the cadre in this photo. We are trained Babinsa. Babinsa is a part of the army, and also we are using the Prolanis cadre. This is the cadre for the chronic disease. By simply teach them to count from 6 meter and for the patients. So they can detect the moderate visual impairment, and the sensitivity and specificity is also high. Usually we use them for screening the cataract in a mass cataract charity program. And this is the core function of the key informants in eye health programs. They can do the community outreach by doing the door-to-door screening from the neighborhood. They can do health promotion or health education by raising awareness through targeted talks, and they can do the referral coordination. Yeah, usually they will take the patients to the nearby health facility, and sometimes become accompanying persons. Yeah, even though they're not a family, but the family usually ask them to be accompanying person for the patients. And also this can be also the system integrations, because they can collaborate closely with the eye health coordinator or personnel. So the service is more comprehensive. The integration of the key informant with primary healthcare is very important, because it will complement the role of primary eye care, and it will ensure us that we can achieve the universal eye health coverage. And also it's more efficiently, because the resource optimization is there. Yeah, it's help overcome the critical eye health staff and infrastructure, especially in underserved area. But the key informant system has also challenges, have a challenge. There is a gender dynamic that already show in Bangladesh and in Indonesia. And also the resource constraint, they have a limited training resources, inadequate support, yeah, and also the funding mechanism or incentive for them is not always there for them. And also the big gaps is on policy, yeah, because sometimes that we have a very fragmented policy that didn't support the work of the key informants. And also the insufficient integration within a formal health promotion framework that sometimes they only acknowledge the health promotion from the health personnel. And also the time pressure, as we shown that usually the key informants participated in more than one or two programs. So because this is a volunteer, they also have they don't have a specific time for work. So sometimes we need to compelling with the time constraint. But we also have opportunities how to strengthen the key informant programs by conducting a very high quality training. We support them with appropriate technology, and also we give a very supportive policy for them to work, and also a community engagement to strengthen the trust building initiative and also the community participation, so the program is more effective. So for the conclusion, the power of key informant in health covers their indispensable partners. Yeah, the key informant are essential for early detection. As you know that the accuracy is very good. They can help us in referral, and also they can be a trust builder, because as shown in the data, almost all the patient that already identified by them is trust their care to follow the referral. And also they can help us to strengthen the system, because because sometimes in underserved or remote area, the health system cannot reach the population, so they can be a bridge to close this gap. So the evidence is clear. I think the key informants are not just helping us to the eye health programs, but they can also be a transformational catalyst for change. So I think that's all, Dr. Mita. I hope it's not too long. And thank you for listening, and looking for a very active discussion. Thank you, Dr. Mita.
Okay, thank you very much, Dr. Yeni, for such a very interesting lectures. So we will have the discussion in the end of the session, if you don't mind, Dr. Yeni.
Yeah,
So
sure.
for now, I will invite Dr. Fletcher first to deliver the lectures. Please, Dr. Fletcher.
Thank you, Dr. Mita, and thank you, Dr. Yeni. Yeah, very, very clear evidence that key informants will bridge the clinicians and the fabric of the whole society that we're serving. That's very interesting. Thank you everyone for being around. It's a long day for you all. So what I'm presenting is an interesting approach. Hasn't been done before in Western Australia to bridge healthcare gaps. I've done my master's thesis on this. I'm a pilot as well, and so the relevance of that is I can try to fly myself out to serve people, but that's not sustainable. And what we need is everyone coming together to do that. So I've set up a company called TX Global to try to bridge this gap using aviation, a small aircraft that's very cost effective and is sustainable. And that's really what we have to achieve, not just a one-time visit. And yeah, that's important. So this picture I've got is one of my outreach trips. What's more important is the person behind the camera taking the photo. This is a good buddy, and it's very important to have someone with you to achieve small little changes in the community around you. And so yeah, this like just a little bit of a light-hearted tone. We can all try to change the world, but small little changes will be the first step. So what's the problem in Western Australia? It's the biggest state that we have in Western Australia. And comparing the size between Western Australia and Indonesia, both are really large areas to cover. And we have very, very limited resources outside metropolitan Perth. Perth is the capital city in Western Australia. So the current limitations we've got two bar charts. You see the blue areas is where all the metropolitan doctors, that's really in Perth, and this is in Western Australia. So we've got most of our doctors, 90% of doctors in Perth and 85% of ophthalmologists in Perth. And the amount of people doing rural work is very, very little, but the community is not little. So they are definitely underserved, and there's evidence showing that. So in Perth, we are located quite far south, and to reach all the way up to the northern part of WA is quite a challenge. Driving will take hours, 16 hours, 18 hours. And patients will have to drive down to Perth for most assessments, and especially acute presentations. That's a big limitations. There are ways to get patients down. And if you can look at the picture on the left, the top half is really from Carnarvon and north. It's really quite tropical, and the bottom half from Carnarvon and south is a little bit temperate. So the climate changes are quite different, and people don't tend to travel across unless they need to do something important. So what the WA government done is a really good scheme. It's called the Patient Assisted Travel Scheme. So what this does is they reimburse the travel. So if there's a 16-hour drive or more from Perth, then they allow flights to be taken because the flight itself is about 2 to 3 hours. So like from Perth to Bali is about 3.5 hours of flight. So you can imagine Broome is really closer to Bali than closer to Perth. And the patient-assisted travel scheme also subsidizes the patients with an escort, with accommodation if they have to stay overnight in Perth. But this is just a subsidy. It's not, patients still pay out of pocket somewhat for their travel. And that's all to get them to Perth to get some treatment. And we have to think about ongoing treatments. We've got to think about what if there are complications following the treatment, like post-op complications. So right now, we've also got, apart from pets, for more emergent issues, we've got Royal Flying Doctor Services. They fly a nice aircraft, PC-12, all the way from Perth. They've got a few hubs that they've got it in Perth, they've got it in Mikatera, Kalgoorlie, and Port Hedland. But the cost of all this is huge, humongous, very, very high cost. And they are not just a transport service. It's really for very emergency type of evacuations that they do these transfers. And right as of now, they've got about 8,000 yearly transfers. So I'll show you the cost of everything in just a bit. So the cost of a RFDS emergency evacuation is Aussie dollars 7,400. Just add 4 more zeros behind. I think that will be a rough estimate of what it is in Indonesian rupiah. So that's per patient, and that's quite a recent budget estimate based on 23-24 numbers. And when they are not in such a hurry, they use a PETS service. And the PETS service in year 23-24 financial year, it costs almost $34 million in Aussie dollars. So divided up with the number of patients, number of trips from the whole of Western Australia, it costs about $505 per patient. So imagine if we can shift the funds, how much more we can achieve. So I think similar to what Dr. Yeni has presented in the rural remote areas, there are a lot of preventable blindness coming from diabetes and coming from cataracts that we can easily treat overnight. And yeah, the avoidable deaths, not from eye issues, but just in general, avoidable deaths are double. So that's not acceptable. There's no way we should be accepting these numbers. So what the solution is, so we've got the issues. So what the solution is to fly out in small little aircraft. It's good in a sense where it can land in a lot of small airstrips. You don't fly to commercial large airports where you need long landing runways. You can land in grass strips, and it's generally comfortable. I'm sure some people have a little bit of a fear of heights or fear of small aircraft. Yes, almost like sitting in a boat compared to a cruise ship, um, uh, as an analogy. But this is something that can bring people deeper into the rural remote communities. So the idea is to bring practitioners, procedures practitioners really, to go out to the rural areas to see more people rather than spending $505 for one patient out. If we see 20 patients, just 20 patients, that really covers the cost already. And it does cost a lot of setting. And I will show you some numbers towards the later part of this presentations. And the idea is really, we don't really, the key informants is a really good idea that Dr. Yeni has presented. But what we can also do without the luxury of key informants is a telehealth or video conference to figure out what's going on, work out what's going on. We know what to bring up and what to expect before heading over to see them. So we can also combine the trips with other specialties. We can combine the trips with ENT. We can combine the trips with physiotherapists, podiatrists. So in the six-seater aircraft, 5 practitioners, 1 pilot goes up, and we can do a lot of outreach work in just one day. The benefits of this as well is we get higher uptake from practitioners. Not many practitioners wants to go out to stay out for days or weeks, and the ability to come back on the same day is quite an important thing. So people can have their family going to schools in Perth and having their friends and networks staying in Perth and doing other work in Perth to serve the population of Perth while they serve the rural remote community. So what can be achieved as well is this small little aircraft brings 5 practitioners. You can land in different small little airports around a 1 hour vicinity of each other, and they can come back on the same day, or we can stay the next day and come back. And that's the flexibility of because we as we all have experienced, there are surprises whenever we do anything. So we might take more time. We don't end up missing the flight because we can control when we fly back. So how do we justify the cost of flying? It's in general, it's much cheaper to fly light aircraft compared to flying commercial, compared to RDS. I'd like to give a plug for Alliance Outback Vision as well, which is a very, very good initiative. A lot of hard work has been put in over decades. What Lions Outback Vision has done is they have got a Lions Outback van to go around Western Australia. In some places up to 4 times a year, some places 2 or 3 times. And they've got equipment on the van to be able to do lasers, to do assessments and screenings, and of course some treatment. So what I'm presenting really complements what they do as well, because we don't stay out there. So what they have achieved is crucial as a fundamental service. So the higher cost is pretty affordable. So it's about $2 per kilometers compared to ambulance transport. And the reason why it's cheaper is because it flies faster. It goes faster, covers a larger distance at a larger time. So there's a small little Goldilocks zone where if it's too close, you might as well use a vehicle. If it's too far, then you might as well fly commercial. So there's a nice little Goldilocks zone that we can use. And of course, once we land at the airport or small little grass strip, we need to have the locals to bring us to where we can see the patients and do assessments or even eye injections. So when we do a cost-benefit analysis, of course, as we try to save the world with this mission, if there's no money, there's no mission. So we need to figure out how to move the money. To move the money, so we talked about the RFDS is $7,400 per trip, and PETS is $505 per trip. And just running the RFDS aircraft at PC-12, which is on the bottom of the screen, running that is at most $3,000 without a doctor on board. With a doctor on board, double the cost. And weighing the speed, the PC-12 flies much faster. But weighing the speed together to make it a fair comparison, the smaller aircraft is called a Piper Saratoga, which is on the top of the screen. It costs about 800 to 1,200 per hour compared to the PC-12, which flies faster, which is 1,200 to 1,800 per hour. So it's still cheaper, and that's comparing on a even scale. So there is evidence to show that there is a lot of cost savings and benefits that we can institute. So now there's money, we can do the mission. This is a picture of the different areas that we've divided WA into. So this is called a WA Country Health Service administrative regions. So a lot of names over here, but it will be much clearer in the next two slides. So if you see the purple star is where Perth is. So it's a very, very large area that Perth metropolitan doctors have to serve, and a large area for the patients to travel to us. So we have used the PETS numbers and compared it with the different areas, and this areas that's highlighted in red, boxed in red, shows that with just moving the PETS money to flying, and we're flying once a week. So it's not too far and few in between. So doing all the flying, these areas benefits. So the areas that benefit are the yellow stars. So if you can see, this is pretty much the Goldilocks zone. It's not too far away, like the Kimberley, which is in green, but it's not so close that we can just drive. It's cheaper to drive anyway. So the ability to serve these areas, and we've got monetary proof that we can save money using this mode of transport. So what does it mean for us? PETS itself is obviously still very useful because the patients can come down and they can come down to see a few different specialists as well. So it's, however, a different funding pool. PETS is from the state government, and unlikely they will be very keen to move money around because the individual health service has the different funds. So it is also not to replace the Royal Flying Doctors. We can't transport, we can't do CPR in that aircraft if something was to happen. And there are these cost inefficiencies, and these numbers are just calculated from ophthalmology numbers. There are other specialties that needs to get their patients down as well. So at this stage, there is strong demand, and with all the numbers of morbidity, mortality that's going on, status quo is not good enough. So That's the end of my presentation. Thank you all for your attention. I'm happy to take any questions with Dr. Yeni as well.
Okay, thank you. Thank you very much, Dr. Fletcher. That was very interesting. So I really hope for some questions in the chat box, but before then, I will ask first to Dr. Yeni first, I think, regarding the key informant, Dr. Yeni. You've stated earlier in the lecture that I think the rewarding system for the key informant is not always good. Do you think it's really fundamental? Because I think it's like a short way to like lift up the effectiveness of the work of the key informant, right?
Yeah.
And is it always the rewarding system, is it always with the incentive, or is there any other way to keep up the motivation of the key informant?
Yeah. Thank you, Dr. Mita, for the question. I think it's a very important issue because, actually, all the key informant, not all the key informant, but mostly the key informants is coming from the health cadres that very familiar to other health program, such as the chronic disease or reproductive health, yeah, in Indonesia. And I think that when I was a child, I really known that there is a cadre for reproductive health, yeah, and it's very well known, a very respective person in our neighborhood, yeah. And the program is very successful, how to hold the population growth that they, yeah. And I think that all of them having an incentive from the governments, but nowadays the incentive is not too popular. It's only for specific programs and usually funded by the NGO, not the governments. The governments only give a very small amount for them, and it's not based on their performance. It's only like, it's a fixed number of the incentive, and actually it's not too high, yeah. When we're talking about how the incentive and in what kind of way that we give the incentive for the key informants, actually there are a lot of study, especially in eye health, eye health school programs that compare the teacher as a key informant. Were they more interested in having a money as an incentive, or they're having sunglasses for the incentive? And I think it's different in every country. Yeah. In China, it showed that the teacher is more preferably to choose the sunglasses better than money. In Indonesia, maybe it's not the same, but we don't have any studies yet. So yeah, until now, currently the incentive is usually is for the health cadre in community is money, and for the teacher in eye health school program, usually we give them glasses, reading glasses, or distance glasses, Dr. Mita. Yeah.
Thank you, Dr. Yeni. So I would like to ask Dr. Fletcher too. You've stated that the privilege of having key informant is not always there. So how you said that before you go to fly, you coordinate with them with like video conference or else. Who's the one who helped you to create or prepare that? Is there? I don't think there will be any survey team because it will cost another money. So, how you do that?
Oh yeah, that's an excellent question. A lot of the remote communities are Aboriginal tribes or indigenous tribes. What they do, because it's very hard to get into them, so we would communicate with an Aboriginal liaison officer, who speaks their dialect, speaks their language, and then they will try to rally the troops on the day that we come. That's one option, and on the larger rural towns, like the first few um, slides that shows Carnarvon and Geraldton, there are nursing posts. There are smaller emergency departments run by the general practitioners. So the general practitioners would see the patients and they refer on. In the current landscape, they are referring directly to the metropolitan hospitals, but there is room to change this system.
Thank you very much, Dr. Fletcher. So I see there's several questions in the chat box. The first question, I think, from Dr. Regina for Dr. Yeni. Dr. Yeni, while key informants play a vital role in the community eye health, many programs struggle with sustainability. What structural measures could ensure long-term support for key informant?
Yeah, I think this is a very interesting question, and it's quite hard to answer it because, yeah, we've seen a lot of programs using the key informants. Yeah, I think a very a program that have a good grand design on long term, it will be more successful than the incidental programs. And also sometimes that the program that was developed by the government in Indonesia, usually they have a more successful program than from the NGO. Uh, it revealed that if the local government or the local government have a political will to fund the programs, the sustainability is more better than the non-governmental programs. But we've seen several programs that funded by NGO that was also have their sustainability, and maybe it's not sustainability, but the models can be adopted by the local governments, such as using the community eye health personnel in NTB, yeah, in West Nusa Tenggara. They're still using the same personnel to find the visually impaired person. So yeah, some of the factors that can related to the sustainability is political will, funding, and also the incentive for the key informants, because that's what make their commitment last longer, Dr. Mita.
Okay, thank you. And Dr. Fletcher, this program that you've done, is it mostly governmentally funded or both or mix or mostly
What
NGO?
what I've done so far is to start slow, and what I've done is to see urgent care patients, not ophthalmology, and that's funded by Medicare, which is a federal pot of money, not the state money. But the state would have the opportunity to fund it.
Mm. Thank you, Dr. Fletcher. And so there's another question from Dr. Mevina. I think it's for Dr. Fletcher. Thank you, doctor, for the lecture. I'd like to ask about which categories of patients or ocular diseases are eligible to use PATS for ophthalmology services, and what parameters can be used to evaluate the success of PATS in improving ocular health outcomes.
Thank you for the question. The pretty much anyone who's referred from their optometrists or GPs can access pets as long as they're coming to see us in the metropolitan area. The issue, I think, at this point is it is a means to an end. So people are using that to fund their travel down. So it reduces the barriers of transportation so that they can access healthcare. And similar to Indonesia, healthcare generally in the public system is free. The waiting time, however, is a very different story. So it's more of a means to an end. There's no other options. So it's not the outcome is quite binary. It's either they get their care or they don't get their care. So until we develop a parallel system, then we can compare which is more effective, which saves more money and achieves more.
Thank you, Dr. Fletcher.
Thank you.
So the next question, I think for Dr. Yeni, maybe, from Dr. Florentina Priscilla. I would like ask more about the cadres as one of the key in the community health. How can we best motivate and empower cadres? I think it's a bit similar with the previous question, but maybe you want to add more, Dr. Yeni, regarding this?
Yeah. Thank you, Dr. Priscilla. It's very important to motivate the key informants that they're part of the change. They're the leader for a change situation, right? So usually, with a good training program for them, the model is also included in we explain them how big is our problem, how big is our problems, and the problems cannot be solved without their participation or commitment. So it will give us the confidence with the skill that we give in the models, and also the self-esteem for the key informants, so they can work in their community. So I think the good training program and also motivation for them is very important. And of course, the incentive also, it's not always money, but incentive is very important. Yeah.
Thank you, Dr. Yeni. Dr. Fletcher, do you want to add something on this? How you motivate other people that work with you in your program?
I think it's quite a bit of a challenge to get people to take time off to do this outreach trips and to make big changes because they've got to wake up early, fly out, come back late. It's at this stage, it's a lot of goodwill that we have to recruit. Until then, once it picks up and everyone wants to do it, then it makes it easier for everyone. So it's just a peer pressure thing that we hopefully can achieve.
Thank you, Dr. Fletcher. So another
Dr.
question.
Mita, I would like to
Yeah.
add something because
Yeah.
this is from my experience. The cadre or the informants that involve in our programs, usually it will bring more proud for them if we ask them to see the result of our program. So, like my experience in childhood blindness, the cadre can also accompany the patients to go to our hospital to see that the children is already operated by the ophthalmologist, and after that, from the follow up from the children that cannot see anything, after surgery, the patient can see clearly. It also bring joy for the carers, for the key informants that make a stronger evidence that they do make changes for their community. Yeah.
Thank you, Dr. Yeni. So they have to be involved until the end, so
Yeah.
they can feel the result of their work, right?
Yeah.
Yeah. Thank you, Dr. Yeni. And another question from Dr. Dani. Good evening, speakers and participants. I'd like to ask Dr. Yeni. We know that the role of key informant is important in addressing the gap in Indonesia. How can we ensure the quality of the key informant itself? Is it possible to provide continuing education or certification, like formal certification for to maintain their quality? And what's the challenge?
Yeah. I think thank you, Dr. Dani. I think I said it earlier that a good training program should be there for them, so they have a very good in knowledge and also in skill. Yeah. Uh, Before they go to the communities, we need to make sure that they have a skill and knowledge that we want them to uh, to have. Yeah, so they're in other way they have a competency in doing the work that we want them to do. In Indonesia, actually, they for the health cadres, they must have like 25 competency, yeah, that they should have, including the communication skill, including how to measure the basic health examination, like how to do the scale body weight, yeah, make sure that um, the height of the patient, something like that. They already have 25 competence. But for eye care, they weren't there yet. So that's why we need another a training program for them. And with their basic 25 competency, I think it's not very hard for them to to mastering the knowledge and skill that we want them to do, Dr. Mita. And I think that for the conclusion, for Dr. Dani's question, is a good training program should be there, and we need to make sure that before they go to the community, they have the skill and also the good knowledge that show by the like the accuracy of the agreement between the gold standard and so on. Yeah.
Thank you, Dr. Yani, because I think they came from different backgrounds.
Yeah.
Not all have a same knowledge about the health.
Yeah.
So training is important, Dr. Yani.
Yeah.
Okay. Do you want to add something, Dr. Fletcher? Do you have any suggestion for training the non-medical personnel, maybe?
Yeah, probably we can start to use AI, but this will be a conversation that lasts for another 10 hours.
Yeah.
Yeah.
Yeah. Okay. Thank you. Actually, we have passed the time, but I will ask you one more question, Dr. Fletcher, if you don't mind.
Yeah.
It's from Dr. Desrina. I'd like to ask Dr. Fletcher what forms of collaboration typically occur between philanthropy organization, government, and communities in delivering health programs.
So the RFDS, which is the Royal Flying Doctor Service, relies a lot on donations. And fortunately, we've got large mining corporations in Western Australia that does donations. Ultimately, it comes to the federal and state government to provide funding for equal healthcare for everyone. But equal doesn't mean it's equitable. It's hardly equitable in the rural remote areas, which is why we are pushing for all this. So in short, the funding it comes from both government and donations.
Thank you, Dr. Fletcher.
Thank you.
If you don't mind, Dr. Yeni, one more question to close our discussion from Dr. Jane. Dr. Yeni, in many community-based eye programs, key informants are often the first people who notice eye problems in the community. From your experience, how can we create a system that not only brings them on board, but also keeps them supported and motivated so they can continue to make a reliable contribution over time?
Yeah. Yeah, thank you, Dr. Jen. I think that it's the same question like the previous question, but I want to more highlights about a good license, yeah, a good communication between the program manager and also the key informants, yeah. And the second one is continuing training for them, yeah, continuing training, continuing a relationship with them that can build up along the way. So they will always attach to our programs. Yeah, by doing, just saying, how are you? Do you have any problems? Something that can follow up our connection with them is very important. Yeah.
Thank you, Dr. Yeni. So I think we have passed our time. Actually, thank you very much, Dr. Fletcher and Dr. Yeni. We learned a lot from you both. And so before we end up our meeting, usually we do take pictures. So I will ask Dr. Devina to help us taking pictures, Dr. Devina. And for all the participants, I will announce also that we will have another Australian-Indonesian joint lecture next month on the second Tuesday of the month. So the topic will be about the oculoplastic and tumor. So make sure you'll be there. So please, Dr. Devina.
Okay. Hi everyone. Thank you for joining this lecture. I will capture. Can you open your camera? Okay, I will start in 3, 2, 1. Give your best smile. Cheers. Okay, another page. Okay, 1, 2, 3, smile. Okay, one more. 1, 2, 3, smile. Okay, thank you, Dr. Mita.
Okay, thank you everyone. Thank you Dr. Fletcher, thank you Dr. Yeni. Good night everyone. Have a good rest. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Dr. Mita. Thank you, Dr. Fletcher. Nice to see you.
Thank you all. Much appreciated. Thank you for the opportunity. Have a good rest.